Do you want me to stand up? No, sit down.
Right, attention again, please. Yeah. I've just started live streaming again. Right, we're back in here. Just to let everyone know that we're in a pub full of real people. Yeah. Yeah. So this is the questions for Corbett section. It seemed that when I thought we'd finished it actually carried on a bit, so there was another 10 minutes of all the chatting on and stuff like that. But I clicked the end broadcast, but then it comes up as though, are you sure you want to end broadcast? Now, there's always something.
Before we take questions, I hope that why I started off talking about HIV was that's why I started speaking out last year about this, because I was retired. I'm retired. I'm technically a pensioner, right? So I live on my university pension and my state pension. So I didn't have to do any of this. Yeah. When I opened the paper last February, and I saw all this, and all the HIV scientists that questioned it from the 1980s and 90s, I became friendly with professionally. They were involved in my doctorate, and I'd worked with them since the 1990s, in the 2000s and the 2010s, and at the beginning of the 2020s, Peter Duisberg, David Crowe, the Perth group of scientists who proved that HIV has not been isolated, right? And so I knew all this stuff that we heard about COVID last year from the 1990s. So I got a doctorate, a PhD, on the basis that the PCR test is not a diagnostic. It's page 71 in my PhD. It was part of my viva, my examination. Yeah, I had to stand up for 2.5 hours and argue it. That's how you get a PhD. You don't just do a written document. You argue with a team of experts. Yeah. So how could I not speak out last year when the government's saying we're diagnosing this with PCR? So I approached on email the head SAGE scientist for the testing of SARS last year, Professor Zambon, who's Professor of Virology at Imperial and on the SAGE group last year. And in May last year, I had an email communication dialogue with her over a couple of weeks. I asked her, where are the live samples, Because the Drosten PCR test for SARS-CoV-2 used a computer algorithm to knit together the genetic structure of the virus, in silico modeling it's called. And she said to me, dear Dr. Corbett, blah, 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 there's no fieldwork material, i.e. there's no live virus from Chinese patients. That's why the Drosten test used in silico modeling, yeah? There's no live virus. Interesting. And Christine Massey, Google her, fluoride campaigner in Calgary, in Canada, North America, has got hundreds of freedom of information requests to individual countries, national health organizations and labs asking for live virus samples. Do they have it? And the answers are all in the negative. So I got this from that person that the British government had running the tests last year in 2020, saying to me, there is no live virus, no fieldwork material. There is no reference standard, that's a medical term, a gold standard for those tests, for the PCR test, yeah? There's no gold standard. So there's no isolated virus to compare the cycles of the PCR with, right? And PCR, I learned in the 1990s, the more cycles you do, like the HIV antibody test, the more likelihood that the polymerase chain reaction will amplify contamination and cross-identify that incorrectly as viral material. And that's why so many people with no symptoms were told to stay at home. That's why everybody, all of us here, were treated like we're ill when we're not. Just like my patients from the 1990s with HIV were given a test result and told they were ill. Yeah? One of my PhD patients told me, 1996, he said, HIV was my way out of being a headmaster in the 1980s. Medical redundancy, they said I'd be dead in a year. He said, it's 7 years and I've never had a sick day. But I got out of a dreadful career. Who wanted to be a headmaster under Thatcher? Yeah? Yeah? So he used his diagnosis. Clever, clever. Hats off to him. Never ill. In fact, he's a little bit on the weighty side. Yeah? A little bit obese. But not ill. Yeah? So exactly the same as last year. I just wanted to bring that up to date before we take questions.
Oh, okay, yeah, that's great. So it's questions for Corbett time.
Regarding the HIV, obviously, in them days, the media played a big part.
Yeah.
So when you spoke to your fellow professionals, because I assume when you sign up to hospitals, you sign up. So what was their reason by virtually playing God and condemning people to death?
Because the way medical authority works in hospitals and the way health services work, it is military in a way. I mean, nursing used to be very military. You know, the matrons directed everything. And perhaps we need a bit more of that back because it's laissez-faire now, isn't it? A bit of a mess. But there is a sort of, it is military in the sense that you know, doctors are never questioned. Well, they are now, and they have been in the last 30 years, much more. But the whole of the technology is not questioned, yeah? You know, the tests are not questioned, yeah? The validity of the tests. And most physicians know nothing about the tests. The tests are done in the lab. I didn't know anything about the tests until I went in the lab and started, you know, look, it's like the engine in your car, you know? I know where it is, but I know it's under the bonnet. Well, I hope it is. I mean, I hope it is. It was when I left it. But, you know, now if you ask me, Kevin, do you go to that engine and where's the carburetor? Where's the this and where's that? And I'm going, I'm not a specialist. I get an expert. I get the mechanic to do that down at the local garage. He knows all about that. Yeah? And he assures me it's all right. But, you know, it often isn't, is it? And they have to bring it back for a second one or a third one or whatever. But it's exactly the same. I know that's a very simple analogy.
Well, if you had two identical results, then the doctor said, well, where's he from? Oh, he's a bank manager. Oh, he's negative.
I wouldn't say they'd say social status, but certainly sexual orientation and race was part of the risk grouping. Black African was a risk group from the late 80s onwards, right? Because the number of people getting ill with AIDS-indicated diseases from those groups determined the creation of those groups as a risk group. Do you see?
Well, I understand, but I just can't understand why the jab's agenda.
Well, it's a very strange test, the HIV antibody test, and I went into the history of how they were developed. And a lot of public health people in America had great suspicions over the use of social groupings like that to help a diagnosis, because there's no physiological, there's no material basis to it, there's no scientific basis to it, right? You know, because you would be testing positive for biological reasons, right? That positive and negative happens in the lab. Those proteins that are called so-called HIV proteins react with the antibodies in your blood, that's supposedly HIV antibodies, for a chemical reason. It's a chemical reaction, right? That's got nothing to what you. That's got nothing about what you do in bed, or race you are, or whether you inject drugs, right? That's what they're saying. It was due to that, right? Because your behaviours expose you to risks. But I was saying, and a lot of dissident, controversial HIV scientists would say, that's not scientific, because a chemical reaction is a chemical reaction, right? A plus or minus is a plus or minus, whatever the person, the patient, yeah? And they lose sight of that through epidemiology, through this concept of risk groups, yeah? So they wouldn't trust those negative results in a high-risk group patient, you see. They weren't trusted. And I remember saying to this doctor, they just interviewed an HIV patient on the ward, and he was HIV positive, gay man, and this is 1987, and I was reading a lot of the research on sexuality and sexual behaviour and what people did in bed. You know, that they started looking at these things in the 1980s, you know. And the doctors, the male doctor, and I said, so how do you think he got it then? And they just laughed at me. And they said, what do you mean? I said, how do you think he got it? Oh, for God's sake, up the bum, like they all do. No, that's you know, that this is the vernacular in the coffee room, you know, and not on the ward in front of the patient. And I said, okay, so did you ask him what he does in bed? And they looked at each other, the two doctors, and said, no. I said, you didn't take a sexual history then. So how do you know that he practices anal intercourse then? Oh, they all do. That's what he said, this doctor, Dennis, his name was. They all do. And I said, do they? Do they really? I said, I've got a study here from the Lancet that says only 35% of gay men in a huge sample of thousands were proven to have anal intercourse. And he said, and he looked at the other doctor, show me that. You know, and I said, you better go back and ask him. Oh, I'm not doing that, he said. And I said, don't bother, because I already have. And he doesn't. So my question still stands. How did he get it? Give me that study. You know, no, seriously, this is, you know, look, you can test HIV positive for biological reasons to do with what your body's been exposed to in the environment your body moves in, for years, yeah? Prior pregnancy, blood transfusion, immunizations, and other unknown conditions. That's what it says in the data sheets from the 1990s, the test data sheets. And there is no gold standard reference for isolated HIV. That's what it said in all the data sheets in the 1990s. Those have been removed now.
Can I just give my comment to that question?
Does that answer your question?
There's who are these people devising these tests? Who are these people deciding why they should test? Why they should? Well, there's a bigger picture now that we're looking at. It's that a lot of these people come from a history of eugenics. Eugenics was a big thing in the 1800s, 1900s. They believe that it's good for the human race if you eliminate the feeble, the weak-minded, the whatever.
I think that's one explanation. Personally, I think a more powerful explanation for the HIV risk groups was that from the 1970s onwards, right, you know, you had within the American and some of the gay communities in the UK, certainly in Western, you had epidemics of hepatitis B, right? And the development from those individuals of a hepatitis B vaccine, yeah? Right? So that's how the hepatitis B vaccine was developed, from a lot of gay men and drug users in America, right? That's how the first Hep B vax in the 1980s was developed, right?
It's the first vaccine babies get when they're born, isn't it?
And why I'm saying this is that medicine was already used to treating these individuals as a closed group, divorced from the rest of society. They were treating prostitute women differently in the 1970s and 1980s, yeah? They were treating haemophiliacs very differently to the rest of medicine in the 1970s and 1980s. They're being injected all the time with proteins, yeah? Yeah? So their bodies were loaded with proteins. The gay men were loaded with lots of proteins from vaccinations, but also from multiple exposures to sexually transmitted infections. Because in those groups, the STI levels were higher. They were higher because people took risks. People's behaviors weren't normalized. People had to meet each other in, toilets or bars, or, it's very frenetic. There wasn't dating. There wasn't
focusing on the group rather than...
Yeah, it was just, you're on the edge of society, and it's really seedy, it's really, whatever. I mean, prostitute women in the 70s they were allowed to walk the streets in Manchester. And a lot of people didn't care because, they brought it on themselves if they got butchered by the Yorkshire Ripper. Because, what are they doing, They shouldn't be doing it, Do you know what I'm saying? It's this whole approach of society is part of the big problem. But in terms of the test result, the chemical reaction, which is all it is, the antibody test, a chemical reaction. That doesn't know what you do in bed, or what you do on the street, or what you inject into yourself. That happens because your blood has been exposed to proteins. And that's what the data sheets show, that if you're exposed to certain proteins, you will test HIV positive. And those need to be excluded. How many people were told before they had an HIV test? Have you had a vaccination? Have you had a miscarriage? Do you think you've had a miscarriage? Have you had a blood transfusion? Oh no, that was never on our list of things to ask. But the data sheets know that, the manufacturers know that, because they want to protect themselves from liability in the courts, from misdiagnosis. Most people wouldn't question an HIV test result, whether it's positive or not. They just take it like a death sentence. And it wasn't a popular job, right? The health centre I worked in had 10 GPs working in it. When I came to work next door as a clinical specialist, guess how many referrals I had for HIV testing? Through the roof from the GPs. They wouldn't do it. They wouldn't do it. They wouldn't take the responsibility, right? But we took the responsibility as nurse practitioners and nurse specialists because we thought the technology was watertight. Bad decision. Technology is never watertight.
Okay, can we take some more questions now? By the way, Kevin's going to drive back up to, is it Druridge Bay in Northumbria?
Yeah, but don't worry, I don't have to rush off.
Jack,
as long as it's not midnight, I don't mind.
No.
Yeah.
What level of cycles were they running with the PCR in there?
Well, the PCR for the HIV patient, the adult patients in the late 90s, they came in around 96. The labs would run them 96, 97, and they were doing something, they're using the PCR viral load, right? Which is not the same as the swab test for COVID. Similar technology, but slightly different variants of it. And they were using, I can't remember the name of it, the Amplicor, I think it's the Amplicor, the ASIM test. And the number of cycles, we sort of had a vague idea that there was a parameter. We didn't talk about the cycles in those days. We obviously did in the lab, but it was so new. It wasn't a machine-run test. It wasn't mechanized in those days. A lab technician had to do it, and it took weeks, to do it, because it had to be verified yeah? And it could take up to 2 weeks for that to come back in the late 1990s. So patients, they wanted it because it was new, you know. They wouldn't use it to diagnose an HIV positive, but adults, but they would. They'd do it on the slide. Doctors would use it on the slide. If the antibody test was negative, they'd run a PCR and they'd say, they're HIV positive because the PCR comes up, they've got a high viral load. Yeah, but the viral load may have been the HLA antibodies if it's female, from a miscarriage or from blood transfusion or from the immunization. Yeah, we didn't know those profiles on patients, and the viral load was just like the weather. I mean, I had patients that were really healthy, and they go to Chelsea and Westminster in London, and they'd be told, that was the big HIV clinic, one of the big ones, they'd be told the viral load is over 100,000. It's like, unless you have the drugs now, you're going to die. Yeah, and they're really healthy, and who are they to distrust that? Do you know what I'm saying? You know, who are they to disbelieve that? Except the clever ones would go to different clinics. And then it sort of got around. A lot of the patients realised that this reading varies. So don't go on the drug straight away. Hold off, yeah? You know? So there was a sense in patients affected. You know, and a lot of these, in the 80s, and 1970s and 80s, there was very common in sexual health clinics that you'd have gay male patients, yeah? Because they're put off going to their GPs. Anybody who goes to sexually transmitted infection clinic, sexual health clinic, is put off going to their GP, yeah? Because the legal act of Parliament governing sexual health clinics is separate. 1916 VD Act, Venereal Diseases Act, set up special clinics, what's called sexual health clinics now, separately to the rest of the NHS. So you have to sign off for any doctor in a sexual health clinic to give any information to your GP. It doesn't automatically transfer. You have to actually write a release, yeah? And if you don't do that, you can sue them. And it was done that way after the First World War so people would use it for confidentiality, yeah? And they wouldn't have their sexual histories blurted out in the community, yeah? So going back to the PCR, it was really novel in the 90s, used for viral load, but used under the counter for adult diagnosis, used explicitly for diagnosing one group of people. Explicitly was the diagnostic, and that was neonates, young babies. Yeah? Neonatal diagnosis was a PCR test, because you couldn't use the antibody tests because they pick up the mother's own antibodies. Because, you know, until about six months to a year, the child has the maternal antibodies that cross-react. But PCR they used as the diagnostic for neonatal HIV. And there it was in the data sheets, not to be used as a diagnostic. Page 71 of my PhD, you know. So that answers your question, yeah. I mean, no wonder they had different viral loads, because they had no reference standard then, and still don't now. Yeah.
So
there is no reference standard for PCR.
So PCR only it's nothing to do with load. PCR just needs to detect one or few more molecules.
PCR is a way of manufacturing, a way of amplifying, magnifying bits of genetic material, right? So if you've got X genetic material and you want to amplify it, you run it through polymerase chain reaction tests through several cycles, and you end up with hundreds of thousands or millions of X, yeah? You start with one, it's like a photocopier, yeah? You start with the original and you get as many as you can, yeah? Now the problem with that is, the way the PCR test is designed is through things called primers and probes, right? Primers and probes identify the bits of genetic material, and they lock onto it. Yeah. But unfortunately, they're not specific. So they lock onto anything that looks like that genetic material that they're designed to detect. Yeah. So what's happened is that the PCR, for example, SARS-CoV-2, is designed, they say, to lock onto 3 genetic sites on SARS-CoV-2 genome. Yeah. But those 3 sites are not specific to SARS-CoV-2. They're also shared with your own genetic material. Yeah.
No.
So when they start magnifying it, amplifying it, photocopying it through the cycles, yeah, and they're also amplifying your own material. Yeah. All sorts of bits of material, as well as the bits they think are viral. Yeah. So and the number of cycles, the number of times you run that test, you put the cycles through, you put the test through cycles. There is no standard number where you stop at. Yeah. If you look at the standard operating policy for the NHS PCR for SARS-CoV-2, it doesn't really give an upper or lower limit. It's interpretive. Yeah. And in the Republic of Ireland, they were going up to 50 cycles. And you see the whole thing, anybody that's worked with PCR in labs knows it's a contaminated technology. You cannot really guarantee a pure sample to start with, and you cannot guarantee that impurities aren't magnified and that they're incorrect readings as a result of that. Yeah.
Okay, can we take another question now?
Yeah.
Jackie, I think you've got one.
I'm not sure you know this, but I just wanted to generally if you knew about anything in the vaccine, you know, the ingredients in this spike protein that they keep, saying, do you know anything about that?
The spike protein, going back to the PCR test, is developed from genetically modeled. It's a genetic model, basically, right? The genome of SARS-CoV-2 is not in nature because it cannot be isolated and purified from people's blood, right? So it's not something in nature that has been diluted and given back to you, yeah? The spike protein is manufactured. The spike proteins in the vaccine is a manufactured genetic agent, right? It is not something from nature that's been diluted. It's not something from nature that's been copied and created genetically. Yeah? SARS-CoV-2, the genome, has not been purified and isolated from nature. And that's in all the papers, except they're not explicit about it. It's in all the research papers because they say it's in silico modeled. They say we assume this patient's got SARS-CoV-2, got COVID-19, therefore we've extracted material from them, we've identified it as PCR positive, means nothing, could be their own genetic material, could be their own bodily cells that's tested positive. And then we've exposed it to all sorts of antibiotics, and we put it into kidney cells and lung cancer cells from patients, and then we put it back into human cells, and it stopped the membrane moving, it stopped the cilia beating on the outside of the cells. Therefore, that's caused COVID. It's all not science. That it's not isolation and purification, right? I mean, Montagnier did a better job with HIV. At least they tried to purify it, yeah? At least they got something like 40% of some of their samples. They said they'd isolated it, yeah?
So based on that then, things like variants and Delta variants, would you say that is a complete hoax?
I'd say it's an artifact of the PCR testing because all they're doing is testing different populations across the UK and saying, oh, we've got a new variant of this. It's like the weather. If you do it, the more you do it, the more you'll find. Because it's detecting our own genetic material.
Are they actually doing was it genome analysis after. So, I mean, but are they doing it on a big enough scale to actually be able to say, as a representative sample, there must be this number of this variant and that variant? Or they're literally just taking the PCR test, a standard.
No, they're
COVID
doing what's called next generation sequencing. They're doing sequencing, they're using a lot of sequencing technology. Again, it is very sophisticated. Again, it's very algorithmic. Again, it's based on computer modeling. Yeah? It's not based on live, purified stuff from the blood of people, right? They never start from there. Yeah, it's always from PCR testing and the results of PCR testing that's used in this sequencing next generation. There's lots of different ways of sequencing, yeah? Very sophisticated. And an analogy I use is this. Look, it's like, you know when the cat's eating the fish and the skeleton's there, yeah? Yeah? Yeah, and all you've got is the skeleton and the bones, yeah? You try and reverse engineer that fish to what it was when the cat ate it. The cat knows what it ate, but you don't know what the cat ate. How do you know you got the right type of fish? Yeah, it's exactly that. But we're not talking about a whole fish bone here with the skeleton. You know, sometimes there's only 2 or 3 bits of the bones. There's not even the spine. Yeah.
So there's a massive leap of...
There's a leap of faith here, because there's a leap of faith. If you go to the original paper, the original research paper that reported this was in a European journal called Eurosurveillance in January 2020. And that's where the Corman-Drosten PCR test was published, right? There was nine authors on that paper, other than Victor Corman and Drosten, Christian Drosten, Victor Corman and Drosten, the Germans. Maria Zambon's on that paper from Imperial College. She's the 8th author. That's why I approached her, right? And in that paper, they said we had to in silico model, computer algorithmic modeling, from this gene sequence to extrapolate a full sequence, yeah? Because there's no purified, there's no live virus, right? There's no patient samples from China. Why not? This came out of China, picked up by Drosten, Corman-Drosten, and it's changed the whole world, the publication of that paper. And it was that paper I used when I talked to Maria Zambon about this. And now, now we're 2 years down the line, we're a year down the line here, 2 years now. And, it wasn't just that paper, that was replicated elsewhere. China released these samples, these gene sequences in gene banks. They're not even samples in a lab that are transferred from one lab to the other. Everything's done through genetic banking, yeah? Gene banks. I'm sure you understand this. So everything's sequenced genetically. So virology now, in the last 20 years, has become a genetic science based on modeling, not on fieldwork material, going out, hunting down the virus, getting blood out of patients. That's almost secondary. They don't think they need to do that anymore because geneticization has taken over. And the history of virology I've looked at, and in the 1990s, very famous virologists warned about the over-reliance on genetic approaches to viral disease. Fredrickson-Rellman and Kalischer, very well-known virologists, not controversial, very mainstream, very well-known academic papers warned that genetically sequenced viruses aren't necessarily equivalent to transmissible agents.
Kevin, is it not the case that this spike protein is produced by our own body? So it's like they're programming our body to produce this spike.
In your ribosomes, which is part of your cells, machinery. That's where the agents that are put in the Pfizer vax and others assemble this spike protein then, yeah? It's not just the spike protein that's problematic in these vaccines, it's things like polyethylene glycol, polysorbate 60, and all the other incipient ingredients that are potentially problematic, yeah? As well as the spike protein. And this is what the public have been learning, is that with these mRNA vaccines, which they are mRNA, not all of them, the AstraZeneca, they are a different technology to the sort of things we had as kids, like the polio vaccine. Yeah? Traditionally, virologists would take the virus, or what they thought was the virus, they dilute it, it's called attenuation, and then they put a small fraction of that into you to develop an immune response to the agent, yeah? That's completely different to what a lot of these vaccines for COVID are doing. They're not doing that. They're assembling within you, yeah? So introducing things into your genetic structure which do alter your genetic structure, yeah? People are being lied about this.
So is your DNA changed after these vaccines?
There is evidence. I have seen papers showing that, yes. People were lied to. Do you remember you told just the deltoid muscle here and it stays there? And then autopsies they've done on people who have died, and there have been some autopsies, not huge, not many in this country, but in America. And those studies have shown that every cell in the body has the spike protein, yeah? And we know this. Look, when I give intravenous injections to patients for years,
your body makes this.
your body becomes a machinery. It uses your cellular machinery to manufacture spike proteins, yeah?
So then, like you know, you've got like a friend or foe system, like in the military, you've got like the immune system recognises a foreign thing and then knows to attack it. But if it's produced by your own body, then it's not considered
but
an enemy.
it's not just the spike protein. Things like PEG, polyethylene glycol, and polysorbate 60, these things are in our food chain already, in our environment. You're exposed to them already. So when you get this in the vaccine, it can cause part of your immune system to overload, the cytokine system, yeah? It can cause all sorts of other problems. One of them is called antibody-dependent enhancement, where you get this fulminating rush of the immune system, yeah? You're already primed for it, then you have the vaccine, so-called, and that's why people are having, some people have died, haven't they, within minutes of having it.
Oh, yeah.
Yeah, I mean, in America, when you look at the VERS data in America, they record much more than we do. People died at the vaccine centres, or they died in the car outside, or a day later.
On the stage,
Yeah.
that nurse, the New Zealand nurse, because she died.
Well, I mean, I do
Yeah.
take all that, but I mean, when you look at the actual data, the actual, what's been reported onto their websites, much more in America is recorded, much more detail than the MHRA data here, much more. And that data should be being investigated. They should be doing autopsies on every death linked to those vaccines. I mean, if it was in my day, I was a health scientist, right? And I just did research on patients in hospitals and interviewing them and doing focus groups. I was a health scientist, not just a clinical nurse. For years, all our interview schedules had to go through ethics committees, some of them for nearly 3 years, before I could even go and see a patient. This stuff has just been fast-tracked through because of the fear and contagion and the investment behind it. Yeah, the investment drives it, and the fear of contagion, like HIV in the public in the 80s, has made people fearful, and that's driven it across the population. But the manufacturers have driven it with the money, the other end, yeah? So
people say, like, people who don't hear what we're talking about think, oh, you couldn't do that everywhere, how do people get away with it? From your point of view, is it basically a top-down approach, and basically you've got a few people who've been positioned in the physicians at the top of the institutions, etc. And then it's like a synergy where most of the, like I say, general normal practitioners and nurses don't really, they just do what they're told.
Yes.
All the small parts come together in
Yeah.
a synergy,
Yeah.
but they're not necessarily aware of it. But you've got like a common purpose lot,
Yeah.
etc. at the top.
Yeah.
And these people have been put in these positions over a number of years to make this basically top-down
I mean,
approach.
I think there's truth
These
in
are
that.
good for you, they'll just fill it up with.
Yeah. I think there's truth in that, but I think
In the 80s, we had little pictures of them flowering.
Of-
No, diesel's poisonous.
yeah, exactly. And you know, all the pictures we had of HIV in the 80s, you know, this thing with knobs on, do you remember? Floating around, you know? They're artists' impressions. They're artists' impressions. But to come back to your question, your point, I'd say that's true. You cannot deny that there are common purpose, you know, there's a mindset. But I think there's a world, what we call a paradigm in science, which is a way of looking at the world as a scientist. And the way of looking at the world as a nurse scientist or as a medical scientist or as a bench scientist is that these PCR tests, this technology is sacrosanct. It works and it's correct and we're using it everywhere. You know, it's the basis of modern virology today. And to say there's something wrong with it is like Galileo saying to the Catholic Church that, you know, the world's, was it flat? You know, and, you know, with all this debate today, I think it's quite difficult. But do you know what I'm saying? It's like being a Galileo again, you know. And there I was in the 1990s, you know, I had to get a PhD through with a supervisor that was a well-known sociologist, very well-known sociologist, and I'm not a scientist. You're not a virologist, Kevin. You cannot dispute this. All you can do as a social scientist is question, you know, show that there's debates, that there are different debates. And I said, well, no, because all these issues I realized about the testing, just like SARS-CoV-2, fits with the difficulty I've had in my career all the way through, you know? Why is it so difficult to get these patients into intensive care? You know, why is there a cut-off? Like, we're not bothering anymore, you know, we do X and then we just give them morphine, you know. It doesn't seem right. You know, it's not right scientifically, is it? If you've got a new disease, you want to be the one that gets your patients well, yeah? No. You know, the idea of HIV is once it's in your cell, it never comes out, yeah? It hijacks the cell and you're infected for life. That's what they believe.
That's the idea.
Load of rubbish.
Do you think HIV was a naturally occurring disease? Or do you think it was man-made to target a certain group?
I don't think HIV is a virus. I think what they've identified is human cellular material, which Andrew Kaufman calls exosomes or microvesicles. The Perth Group scientists, look them up, www.theperthgroup.com. They talked about this from the 1980s onwards, that the HIV tests are not based on any gold standard isolated virus. They're based on assumptions, they're based on chemical reactions, right? And people can test positive for all sorts of reasons, right? And as soon as a patient learns that, they don't believe it anymore. It's like a spell being released, yeah? It's like a spell being released. Or is it? Because once the doctor's given that to you, even if you know it's false, some of it still sticks, yeah?
Well, it's my view that HIV is just one of many markers that could have been identified randomly to push the agenda.
In those groups in the 1980s, there'd be no dispute. No dispute. They were vulnerable. In the 70s, gay men, 1960s, gay men had just been legalized. They were coming into the mainstream, but they were distant from society. Black Africans were distant, haemophiliacs were distant. They're on the edge, these people, and that made them vulnerable. I'm not saying they were targeted deliberately, but there's some element of truth in that. Some element of truth in that. And I went to so much trouble, I can't tell you. I was disciplined and seeing matrons, But it didn't bother me because I thought, well, I'm going to do the right thing, and I got up the tree, even though, and then I realised the flaws in it, and I've tried to do something right since 2001 when I got my PhD, and I published all of this. I published a paper on HIV testing in 1999 in a midwifery journal in the UK, showing that the Abbott laboratory test can test you positive if you're female, if you've had a prior pregnancy. Well, Public Health England, as it was then, tried to ban that publication. They wanted it pulped, and then they had to write an article in response to us, They were so angry that the editor had gone ahead and published us, And that's how I got it out, and that created skepticism, My name in 2000, when that came out in 1999, I was on the register as an MSc, as a nurse, RN, on the nursing register. People said, we're going to report you to the Nursing Council for that article. And I said, go ahead, because all I've shown is what the manufacturers themselves say. Don't you think your patient should know that? Don't you think every pregnant woman that you're going to offer an HIV test should know that? They wouldn't want it. Who would want it?
Okay, one last question. Nigel, you something about.
So I was going to go off on a tangent, really.
Did you have another question or?
Yeah.
Go on.
Okay. One of the queries was in terms of the genetic modelling. Is that actually more or less fiction then, in terms of whatever the model is generating?
I wouldn't describe it as fictional. I mean, I think that's a lay interpretation, and I think it works a treat. It gets the idea over. I think in silico modelling, modelling something in a computer algorithm is how everything's done today, isn't it? They're doing drug trials for years in silico models, where they don't give a new drug to a patient. They model it in a hypothetical cohort, a hypothetical group of, on a computer model, So in silico modelling, to say it's fictional, to say that these genes are fictional, I don't think it's totally true. But to say that they're from nature, they're from a virus that's external to your cells, I think that's incorrect. I think it's true to say they're not. So these genes that they've used to in silico model a sequence aren't necessarily from outside your body. They're not from a foreign agent, which is what they're saying SARS-CoV-2 is. It's an external virus, a novel coronavirus. That's the term, a novel coronavirus, because there's certain sequences they found they think are novel, Well, they've been proven not to be novel, For God's sake, Andrew Kaufman is a psychiatrist, he's not a virologist. He's got a degree in microbiology, and he went through it in a few hours. But they're not looking at it that way, because the worldview that everybody shares is that there is an epidemic, that there is something that's transmissible, Whatever. Look, how many times do we have a cold and then your husband, wife, or whatever gets it, Oh, so you got it off me, Ever lived in a hall of residence with lots of women?
I did.
I have, but as a student, Well, we all did, as students in the 70s, One thing I noticed, and everybody noticed it, was that after the term was well underway, all the girls' menstrual cycles synchronized. Isn't that interesting? Is that contagious? Is it transmissible? Because we interact, So I lived in a hall residence at Reading University, and it was mixed, men and women. And all friends that were female, there was about 10 of us all together, about 4 blokes, 6 women. All 6, by the end of the term, all their monthly cycles were almost the same, Isn't it interesting? Most of them.
Is there a paper on that?
There's loads. No, there's loads of stuff on it. You can look at it. there's this whole point about what's contagious, What happened last year in 2020 was you were told by the government, these are the symptoms, weren't you? You were told the list of symptoms, yeah? Yeah? In old-fashioned medicine, we never told patients symptoms, really, before the internet. Why do you think?
Because it's self-fulfilling prophecy, you think you've got something, and it's psychological.
And they were told, very unusual symptom is olfactory symptoms. Loss of smell, loss of taste, yeah? Olfactory, and that's a Latin word for the mouth and the nose and olfactory symptoms, and that's very unusual. I read that in, I think it's the Telegraph or something. I thought, how we knew that when I was a trainee nurse in the 1980s, we knew that those were everyday symptoms, that people get colds and flu and bronchitis and metallic tastes. And how is that anything new? It's not new. None of those COVID symptoms are new. They're cobbled together, right, and said it's new, and it's due to this, so-called virus, positive test. But you're a COVID case if you're PCR positive and no symptoms. That's a COVID case.
And all the time it was just the flu that went missing for a year.
Well, exactly, but not just flu. And I think we've got to be careful about this, because there have been autopsies done. King's College London did a study on autopsies of patients who died after COVID diagnosis. And that's how I would always describe it, that people have died after a COVID diagnosis. Do you remember that was always on the news? Died after receiving a COVID diagnosis, yeah? That's correct, right? I don't dispute that there's such a thing as a COVID diagnosis, or there's a SARS-CoV-2 diagnosis. I'm questioning what it means, because I don't think COVID's anything new. It's pre-existing symptoms repackaged, right? Repurposed, weaponized against us, right? And the fear
Everyone panicked 2 years ago.
People were primed to expect these symptoms. For goodness sake, we've all had those symptoms every year, yeah? There's nothing new. So people are going to say, oh, I've got it, yeah? They've got the cold, they've got a sniffle, or they've got something else, or they've got a real problem, a pre-existing problem, yeah? Any patient with heart disease gets cough, they get congestion, easily. They get temperatures, they get all sorts of symptoms. A huge overlap between so-called COVID symptoms and others. But the autopsies on people who died after COVID diagnosis, with this, at the core of it, this respiratory problem where they've got like a high altitude sickness, has shown the autopsy results, material, you can't deny, clotting, yeah? Clotting in the microcapillaries, the really small blood capillaries, the really small blood, looking for an easy word, vessels. They're really, the microcapillaries are really almost microscopic, yeah? And so the clotting that happened there is very clear on those autopsies. And that's due to the exposures of those people to things in the environment,
like radiation,
and not just 5G. We're talking about, radio frequency waves, basically, broadly speaking, which has exponentially increased our exposure to that from the Second World War. Yeah, the Soviet Union researched all this in the 70s. Yeah, they had something called radar sickness, where their operatives on radar screens, yeah, they became ill. They called it radar sickness, yeah? It's due to exposure to the radiation. Look what we've got in our homes. Smart meters, mobile phones. God, I've got mine in my pocket. Now, interesting there, I had this, always used to keep my mobile phone here for years in a pocket, Do you know what I mean? It's interesting, isn't it? Then I got a lump the other year. Interesting. No, association, correlation, doesn't mean causation. But
We're all being given a
We're
negative
all-
placebo.
yeah, but we were all told in the 1990s. I remember when before mobiles came in, I worked in district nursing. In district nursing, they got the mobile. In district nursing, who's got the mobile over the weekend? You've got it, Kevin. Oh, it was like 4 times the size of that glass. It was like, oh, I've got the mobile for the weekend. I've got all the patients. I've got the phone. The buttons were huge. It's just a joke. It's like something out of Laurel Hardy. Oh, but you all thought it was great, And of course, we were told there were scientists contesting this, saying there's problems with this, with the radiation, with this technology, and they're all pushed out. They continued working from the 80s, 50s, 60s, 70s. Mobiles came in early 90s, didn't they? And then publicly, it wasn't really till the end of the 90s that most people got one, mid-90s, late 90s. And it's popularised on TV programmes like The X-Files. And they became like cigarettes did in the 1930s in advertising. Everybody's got to have a mobile. I've got to be seen with my mobile, Do you know what I mean? It became a fashion accessory. But nobody thought that there's something wrong. It's not just those, and 5G is another generation of this. It's quite different, even more problematic and potentially toxic and lethal. But what we've got already, what the load we're exposed to already in our homes, microwaves, this wave, this, that, the other, the lights, everything, And you've got to add it all up. That's what I mean by exposures in the environment. Yeah, it's not what you put into your body through an orifice. Yeah, it's these other exposures as well. And then people self-medicating on antibiotics in the 70s. A lot of gay men did that. They didn't want to go back to clinics. So if they had syphilis or gonorrhea, they'll self-med until the symptoms go. And they've still got the problem. Yeah, because all these antibiotics are just suppressive agents. Yeah. They're suppressive agents. They don't cure. They suppress. That's allopathic medicine. It suppresses. Yeah. So all these unhealthy behaviours that people are encouraged to do. Look, in the 70s, 80s, when I started nursing, you'd be handing antibiotics out like Smarties. Doctors would be just prescribing them. They seem to have a bit of an infection. I'll give them a course of antibiotics. We don't need to send it off for culture to the lab. We don't need to do that. Just give them antibiotics, and if they improve, must be the antibiotics. Yeah. Now you can't do that. It's too late. Antibiotic use has had its effect on that generation. You see. Yeah. Anyway.
Okay. Just
any other
one last
questions?
question from Nigel.
Slightly going off on a tangent, but with recent news about the nurses being told that
Glad you
be shot
mentioned
or you're out. What's your opinion on whether or not if there's such a thing going to happen like a post NHS, and whether or not we could form community hospitals?
Well, I think it's a very good question. I mean, I think if you accept that SARS-CoV-2 is a real virus from nature, and you accept that COVID-19 is a real diagnosis, and whatever you believe about that, and I quite understand if some of you want to do that, the logical result of that belief is what the government's doing now, which is what we call in healthcare infection control measures. So you always contain an infection. When I worked in environmental health, I was an HIV officer. I had to do, all sorts of other things. So when we got an outbreak in a butcher's, of infected meat or something, we'd contain it, and we'd swab everybody. We'd go in, and do, contain it, control it, make sure and clear people when we could, That's what they think they're doing now, The government's doing this with healthcare staff now. They've done it with the nursing homes first. The most vulnerable group of care workers. Very few RNs work in nursing homes. Very few professionally registered staff work in nursing homes. A lot of them are healthcare assistants, or they're overseas people from overseas, or they're not a highly unionised group of staff, who is today. That's part of the problem. So they brought in a statute of Parliament to say that from the 11th, from tomorrow, if you're working in a nursing home, you've got to have your double jabbed. And if you don't accept that, you're out, yeah? And that's what is happening in a lot of places. I just spoke to somebody tonight whose wife's just lost a job from tomorrow because she's an RN working in a nursing home and refused to have it. So there we go.
I think we're all very clear about that.
Come back to your question though, I don't think I answered that. So the second bit of it was setting up an alternative, right? I think this is what's happening now. The health service is broken. It's completely broken. It's been broken since like 30 years, really, in my experience. Because I lived through the Shipman, I lived through Midstats, I lived through Morecambe Bay, I lived through Gosport. I've seen it all. I taught all this in universities. And I taught the regulation of healthcare professionals. That was my area. And I taught medical sociology. And I can tell you, it's already gone. It went straight away from the beginning of 2020 when they brought in what I call the Nazified NHS, which is a COVID NHS. So to have anything, you're going to have the jabs, not just double, booster, whatever number of boosters. I think in Israel now it's on the 4th, isn't it? So it's going to go up. It's escalating up. It's, it starts like, this technology starts reasonably. Like coming through the time tunnel tonight, you've got to pay after or before you go in. You can't pay by cash anymore, yeah? Because they want to stop the queues, yeah? Well, I never had queues going through the time tunnel.
Blackwall Tunnel made 2 million in fines last year.
Yeah, so tonight, I've been going through the time tunnel from York and London to Newcastle since 1990, right? And I've never experienced a queue. I think once, it was like 5 minutes. Tonight, it was 10 minutes back at least. Why? Because they just brought in this new technology, right? So there's 10 portals you drive through, 8 of them shut, only 2 open, and queue to bloody get through, because we're feeding the technology. We're babysitting the technology for them, yeah? Because it won't work properly, yeah? I felt like driving right through. If I had a tank, I would have mown the whole thing. But what is the point? But the point is, it's broken. So you've got to do it yourself. Look at general practice. That's been broken for a long time. Certainly gone now. Yeah, they won't see you, and they're threatening a strike. GPs. Do you know that?
Yes.
They're threatening a strike because the government contract with them is that they've got to see you in person. And they're not doing their contract. They're not doing what they're paid to do. But instead of sort of saying we're not going to pay them, they're saying you've got to do the contract, the clinical commissioning groups. And the GP is saying we're not doing it because there's this dangerous disease. We don't want to get it. Blah blah blah. Yeah, infection control. They're applying infection control to the whole thing and limiting you. Yeah, anybody can have it and anybody can transmit it. That's what the public was fed last year about COVID. Anybody could have it. Anybody can transmit it. That's exactly what was said about HIV in the 80s. Yeah. So it's already there in the healthcare professions, that asymptomatic transmission. It's already grounded in people, in the mindset of nurses and doctors, right from their training. Yeah. You will not eradicate it. All you've got to do is get workarounds. Survive this on your own values and your own grounds and reinvent your healthcare as you need it. And I'm afraid that's what we're going to have to do from bottom up. And you're not going to develop a national service to do that. It'll have to be done locally. It'll be different strokes for different folks in different areas. So it'll be this nurse, this doctor that's been pushed out of the NHS, this naturopathic doctor or this homeopathic doctor, or you have to work across different types of medicine, yeah, Where you go for acute care, that's the big issue, yeah? If you're hit by a lorry and an ambulance comes, it's probably no good having a homeopath if you're unconscious and you need a ventilator. You have to go to A&E, yeah? Do you know what I'm saying? So some of it is out of our choice, but most of it, most is chronic, most is not acute, most is not emergency, most healthcare is not emergency care, yeah? And most, I think, you can do without or do with alternatives, yeah? How many times you've been to your GP and they don't tell you the truth, that you're fat and you need to lose weight, or you're this or that, or if you don't, you're going to have a heart attack, or you've got to do this. Why don't you do that? No, they put you on one pill, right? And then they put you on another, then you put on another. When you get to my age, you're on about 10. I'm on nothing, and I wouldn't take one, ever, right? That's just my personal belief, right? I'm on nothing, and I'm probably older than many of you here, right? I'm not saying I'm a role model, but I'm saying you can do this. You can do without the NHS when it's killing you, right? Because the NHS is a dependency culture. That's what general practice is. All general practice has been, since the war, is like a tube for the pharmaceutical industry to funnel drugs into you. That's all it has been. They never use the word cure. They never do anything. They're looking at the computer. You're a number. You're paid for. They ask you the questions like how much you drink, how much you smoke, because they're on their schedule. That's what the CCG pays them to ask you. If they don't ask, they don't get paid. They're not really interested in the answer, right? Just as when they say, I'm going to prescribe this drug for you, you say, oh no, I'm not going to have it. And they say, oh, okay, well, just in case, it's at the pharmacy if you need to collect it. Because they get paid anyway. They get paid, whether you take it or not. You flush it down the loo or not. They're not interested. Majority of them, not all. I'm not saying they're all bad and they're evil or whatever. Don't get me wrong. I worked in general practice as a practice nurse.
Do you take any vitamins? Do you take any vitamins?
I take niacin, I take a couple of things, but I don't take it like a drug, you know?
Like a vitamin D or anything? Because Northern Hemisphere.
I just have a well-balanced, organic, mainly diet.
Right.
And just exercise, and I don't drink alcohol. I gave that up about 5 years ago, and I never smoked ever, and I came from a family of smokers, but I've never smoked. And when I started nursing, you go into the coffee room where you couldn't see the other side of the room.
I was just thinking, would you not be able to test people's blood to sort of like say, you're low in iron, you're low in vitamin C?
Yes, you can. If you go to a naturopathic service.
Because you never see that everybody's worried about everybody's health. But
you can find naturopathic doctors online, and there's a regulator. You can find one that's near your postcode, and they are supposed to be non-allopathic, meaning they don't treat. Allopathic means you treat with something different, doesn't it? Yeah. Homeopathic, you treat with something similar. Yeah. Allopathic is there's basically a pill for everything. Yeah. Every symptom has a pill equivalent, yeah? And that's an allopathic approach is what medical schools are based on since the 1920s, right? They threw out naturopathic and homeopathic approaches and osteopathic approaches, especially in this country. They've pushed out, and in America, naturopaths have pushed out, but the osteopaths stayed in a bit, even though they were pushed out on the edge. They share, the medical doctors, the allopathic doctors, the traditional orthodox medics, and osteopathic doctors in America share similar curriculum. That's why you get people like Carrie Madosh and Sherry Tempany. They've worked in A&E departments. They've run A&E departments because their curriculum, how they're trained, overlaps with traditional medicine. Yeah, they can do emergency care. And look, we had a paramedic here a minute ago, but a lot of nurses, I worked a bit in A, not a lot in A&E. I worked as a custody nurse, as a forensic nurse practitioner in police custody. It's like being a charge nurse or an A&E sister on your own. Because people in custody are arrested. A lot of them are drug users. They come in with multiple, they're going to have seizures, fits, they're going to have cardiac arrests from things like cocaine and all sorts of things. So if you work in custody as a nurse practitioner, it's like, I always said it's like working in ER, the TV programme, but there's no George Clooney, because there's just the nurse, and it's you. And, when somebody in front of you, you're the only nurse having a cardiac arrest in front of you, they're 35 at 4 in the morning, and there's you and a small defibrillator, and you've got a custody sergeant who can do chest compressions, but that's all. And that's hands-on medicine, that is. That's real, that's what we all do, not nurses and doctors, and all healthcare professionals are taught to do that, When you've got somebody who's not breathing and their heart stops, I would say that's the best thing, not best thing, it's the one thing I know exactly what to do. There's just one thing to do. There's no differential. There's no, should I do A, B, C, or D? I know exactly what to do because it's life-saving. And that's exactly what you're trained to do in healthcare from day one, yeah? And all the sergeants say to me, well, everybody else is running around panicking. You just seem very cool. And I said, well, to be honest, give me a cardiac arrest any day rather than somebody who's going to spit at me and call me effing blinding and hit me, which is a lot of custody work, That's more difficult to deal with. In a way, horrible thing to say, but, that's the reality that I'm saying.
So
that
we should all be building up our immune system.
We should be building up our immune systems, looking at,
Is that something from the 90s that you looked at as well?
It's something that I learned a lot from patients in my sample, from the AIDS patients in the 80s and 90s, right? Who started looking at, they saw people dying in their communities, drug users, gay men, and they started looking at their health. And they started doing, what people have been doing last year, organic, more vegetarian, less meat diet. The epidemiology of cancer shows that processed meat diets heavily correlate with cancers, yeah? Even the NHS says that, yeah? And, I'm not putting you off your sausages and whatever, but heavily saturated meat diets are, heavily correlate with, look at the China study. It's a very easy study for anybody to read, and it put you off meat eating. And the thing is, we saw this with our patients in the 80s. The AIDS patients, towards the end of the 80s, early 90s, became healthier, right? And they were HIV positives. They weren't AIDS cases. They didn't have any of the indicated diseases. They were just test positives, yeah? And they got healthier because they started doing less recreational drugs, less recreational sex.
That's something you actually see, yeah?
Yeah, you saw it. It's well documented in research. You can get some research studies showing it. And they say that the new antiretroviral drugs in the 90s did that. It wasn't. They came in, people's health indicators changed before the drugs came in. Just like, the vaccines for infectious diseases cured the infectious diseases. They didn't. They went down before the vaccines came in. So many people have proven that.
Okay,
Yeah.
Excuse me, I'd just like to bring the live stream thing to the end. We'll carry on. Just let people know who've been watching the live stream.
Yes.
We're at the Porky Pint in Billingham, and we're going to get guest speakers like Kevin every week. Well, not every week, but as often as we can. And the idea is to at least keep a local place open that we can come to and support Paul Henderson, who's been fighting for freedom, and so. He's standing up against the authorities, the council, and he can only really do that. He can only do so much. If there's the more community we've got supporting him, then the more support, more strength we've got. So we've got speakers such as John Hamers coming on the 8th of December. Got a few other people lined up. We've got people speaking on law, David Edelman, People's Lawyers, coming in January. And there's about 3 other people, but I haven't firmed up yet. But it's great that we've started this off last week with Mark Steele and now with Kevin Corbett.
Well, I hope that that's been interesting and useful, and thank you very much for listening and for all your questions. And I hope I've given you something. You know, I would refute being any type of expert really, but you know, I don't like the term expert because I think it sets up a perception. You know. And I'd say all of you are experts. Types of questions you all ask me, even those of you who've come to me during the break and asked questions, shows to me how expert everybody is and can be. And that's exactly what the sage scientists and these sorts of medical scientists and authorities like the government and the politicians, they see the public as stupid and ignorant and as people to be herded. And that is true. A lot of bench scientists think that. People need to be told what to do. That's why all these Nazified signs on the floor in supermarkets and things. Walk this way, because the virus goes this way. It gives people an idea. They're being herded. Now, sociologists, we know that the public isn't stupid. The public can look things up themselves, can teach themselves the most arcane, hidden science, and can find the flaws in it. Because you live through it. You live it every day. Yeah? You were all told in March 2020 that you could have it and you could transmit it. You were all told that, but you didn't really believe it, otherwise you wouldn't be here. Yeah? And you've gone off. Look at your learning since January 2020. Look what you've learned in 2 years. And tell me you're stupid. You're not stupid. You're absolute experts. So well done you.
We've learned loads. Anyway, thank you, Kevin. I know you're going to drive up to Scotland.
No.
Scotland now, yeah. And don't worry. We'll
time tunnel, isn't it?
Yeah, we'll cover your fuel expenses. That's the least we can do. Okay, thanks very much.
Thank you very much.